That's fine. Okay, good morning. So I'm just going to actually, different to what might be on your programs, I want to just go through an overview of care in motor neuron disease, and towards the end, more specifically with reference to Northern Ireland. So a brief background, and then a little bit just about a qualitative study of palliative care and of care in general at the end of life in motor neuron disease, which some of the audience might have heard snippets of before, so apologies if it's a little boring. Okay, so just basic epidemiology that we did when I was a registrar, linking in with Orla Hardiman in Dublin and Professor Victor Patterson in Belfast, was very much consistent with other westernised nations. So the peak incidence is in around the age 60, 65. There's a bit of a peak earlier in males. And what's always been borne out in research over the last 20, 30 years has been that there is that peak and a tail off in the later years, and people had often wondered why it differed from other neurodegenerative conditions like Alzheimer's, where incidence increased as time went on. But there appears to be that peak, and it probably is due to the interplay between genetics and environment. So some of the, actually let me go back, it's just important to kind of quickly note the largely aggressive nature of the condition. So 50% dying within with less than 3 years. 20% notably, however, will live much longer in the 5 to 10 year bracket. And it can be easy enough to pick out those longer livers, and that can be very important in terms of planning care, and certainly probably more important to pick out those that are much more aggressive and have aggressive disease, because really time is of the essence. Briefly, just going into the NICE guidance, which was published very recently on motor neuron disease and kind of brought together comprehensively all the components of care. In terms of prognostic factors, they remain the same and have done so over the years. At the very bottom is actually the most useful predictor of how someone will get on, and I often use it in clinic with patients because they naturally themselves want to know what is the tempo of their condition. Tempos don't actually tend to change very much, unless of course you miss things like respiratory disease. However, that time from the first symptom to diagnosis gives us the best estimation of someone's tempo. So if somebody has presented in March to their GP with some symptoms and they're diagnosed within 6 months by having negotiated their way through the process to get into hospital and have investigations done, that will be a very short window and generally predicts quite a long or quite an aggressive tempo of disease. 18 months to 2 years is often a kind of a typical kind of time period for patients with a slightly slower progressive disease. But certainly early bulbar problems can be a poor prognostic factor. Weight loss is a very big prognostic factor, poor respiratory function clearly, and a declining respiratory function most importantly, so looking at something over a period of time. Older age, and having been in the clinic a few more years and getting a little bit more experience, I tend to be beginning to start to tell people about that impact of older age. You often will only get them in the clinic a couple of times, maybe 3 times before they're no longer really able to come. So you really have to talk to them about as much as you can squeeze into those couple of appointments if they are older. The ALS-FRS is in the literature. It's really a research aid. It's not something that's terribly useful in the clinic, but yes, there has been some relationship between poor prognosis and a poor rating scale. So ALS is this interchangeable word. It's just because I've done different talks and I've put different slides together, but ALS is another term for motor neuron disease. So it's progressive neurological disorder that affects muscle control ultimately, and it's due to the underlying problem is obviously the degeneration of the motor neurons in the spinal cord in the brain. So the upper motor neuron is the path. So the motor pathway starts in the cortex, it comes down through the brainstem and down into the spinal cord. That's what we refer to as the upper motor neuron. It's relevant because of the next slide. As the motor neurons come down, they synapse in the anterior horn cell, and that's the beginning of the classical lower motor neuron. So it starts here and it comes out into the muscle. And damage within either one or the other, or a mix of the two, is what you get the signs, is how the signs are produced. So for example, the upper motor neuron will give you more spasticity, which in some of the younger patients impairs their gait, and can be modified with exercise and pharmacological agents, which we'll hear a little bit about probably. In terms of the lower motor neuron, you get more wasting and weakness, and that's and obviously the kind of hallmark of this condition is a combination of the two, and that's why the Americans use the term amyotrophic lateral sclerosis. The amyotrophic is the lower motor neuron degeneration. The lateral sclerosis is the upper motor neuron degeneration. So classically in clinic, you're always trying to see that there is evidence of both upper and lower motor neuron degeneration in a patient's clinical examination. But often you will have only one or the other. Sometimes investigations will help you a little bit, but often you may have a patient with just upper motor neuron disorder, which can be termed primary lateral sclerosis, or PLS, and alternatively then you can have a patient with just weakness and wasting, just lower motor neuron degeneration, and that can be called progressive motor atrophy. Now, you then look using investigations to see if you can find other ways and means of drawing out the missing pieces of the jigsaw. And occasionally in patients, for example, with PMA, you might do imaging and find that there is kind of a highlighted area within that corticospinal tract in the brain that sometimes appears. In patients, for example, with PLS, you might do some neurophysiology and muscle testing, which I'll go through in a second, to try and kind of firm up the diagnosis. But essentially you want a mix of the two, and that's really important to be able to kind of be comfortable that you've got the right diagnosis. But you will need sometimes a little bit of time before those symptoms and signs evolve. People are very taken with the type of MND that they have. And really, that's because they want to know, do I have a fast type or a slow type? Within every different type, there is people who progress fast and people who progress slow. Another way of slicing it up is patients who have sporadic disease or familial disease. So about 85 to 90% of cases, thankfully, are sporadic, but there is about 10 to 15% of patients who will have a family history. And that's very relevant because we know a little bit more about the genetics, which I'll go into in a couple of slides' time. Obviously, the way in which a disease presents can also separate things out. So bulbar cases, about a third of patients who will present with bulbar symptoms. And that is almost always slurring of speech. If you have someone who develops a swallow problem first, that is highly likely not to be bulbar onset motor neuron disease. You will almost always have speech disturbance first and then swallow disturbance very distinctly after that. And that is more common in females. 2/3 of patients then have spinal disease. And that, as you can imagine, so if you think of the spinal cord going from the cervical, thoracic down to the lumbosacral area, the cervical cord obviously relates to upper limb function, so you can have patients who present with upper limbs, weak legs, and then in the trunk area it can present in a couple of ways. One, it can be a bent spine syndrome, so you have weakness around the spinal area in the trunk and they can't stand up straight, or patients who present with incipient respiratory failure, which often they present very late and die very quickly. Cognition is an increasingly recognised problem in motor neuron disease, and people can present. I've noticed it's more often the familial genetic MND cases that often present with a frontal lobe cognitive impairment, which I'll touch on a little bit later. Other descriptions that you might come across include flail arm, which is essentially where you have bibrachial involvement, so both arms are very weak. Other terms used for that are man in a barrel. Don't tend to use that obviously, but you'll come across that. Flail leg, and I mentioned obviously what PMA and PLS are. So this is just really kind of pictures to highlight what we're talking about. So the picture at the top left is a man who has bibrachial variant motor neuron disease. And classically, you will get wasting between the thumb and the first finger. Importantly also, if you ever need to, it's way more relevant for physios, but they almost always have significant weakness of the thumb. It's often the very first place that it will attack someone in their upper limbs, and it's abduction of the thumb, so it's easy to test. They will always have very preserved finger flexors, and finger extensors will also be the first ones to go. But the thumb weakness in extension and abduction is often the very first sign when patients develop upper motor disease within their upper limbs. I've shown a picture in the top right there of shoulders because it's a big area of issue. People who have bibrachial variant motor neuron disease or upper limb onset motor neuron disease, because they have significant weakness or not using their arms as much, they often tend to develop very painful, restrictive capsulitis of the shoulders. And that's easily prevented by physio or thinking about it or knowing to tell families about it. But if it's missed and they end up with a very sore, painful, restrictive shoulder, then sometimes steroid injection can be quite helpful. So a little bit, very briefly, about the diagnosis is that it is a clinical diagnosis, and it often requires a couple of visits with a neurologist to be sure. Yes, we do MRI. We were talking a little bit about some of the signs you might look for, but you want essentially to make sure there are no structural lesions there that can explain the condition. No syrinxes, no brain tumours. You just want a scan that excludes pathology because this disease is diagnosed clinically. EMG is that nerve and muscle testing that people go to Belfast for. Nerve conductions can be slowed a little bit, but largely speaking, they're normal. The EMG is the little needle into the muscle that gives a muscle signal, and the normal muscle should be nice and quiet at rest. Then whenever you action the muscle, you should have normal action potentials whenever you actually move. In a person who has denervated muscle, which is where the nerve supplying the muscle is missing, and that is classical of motor neuron disease, then you get the muscle not being quiet at rest, and you get little fibrillations, which is exactly what the patients notice and feel when they say they have muscle twitches, and something that you obviously can see. When the muscle is activated, it's an exaggerated response, and whenever there is significant exercise, it's unable to maintain. And it differs from muscle disease very easily. Oops. So important is the timeliness in diagnosis. Why we looked at this a number of years ago, it's been looked at by other groups, and it never differs. It's not really that dependent actually on a per NHS or slowness in access to investigations. No matter what different locality this study is done, you still get the same delay in diagnosis of 14 to 16 months. And that is because it's really difficult to diagnose sometimes very early because it's very subtle and the GP isn't going to see an awful lot of the signs. And that's a reality that I think sometimes we just have to accept. It was a little bit longer, that time to diagnosis, in females compared to males. And it was a little bit shorter in bulbar onset disease. The longest median time period that we felt was responsible for the latency to diagnosis was the time spent with the physician before a neurology referral was made. But that, as I said before, is something that could be quite difficult to modify really as a GP. Or indeed, as I said, if they're attending, a lot of bulbar patients will classically go see their dentist about their dentures, and then they might go to see an ENT surgeon, and often their referral won't then come through. Very rarely do you get a referral from an ENT surgeon. And that, I guess, is an area where you could potentially educate, but I'm not discussing respiratory failure. Claire and Catherine will do that later, but it's important just before I talk about the study at the end, just to kind of a brief introduction really. So it's important just to note that neuromuscular respiratory failure is the cause of death in the vast majority due to muscle weakness. There's two elements to it which again are relevant to what I'll talk about. Yes, we have the hypoventilation and the respiratory failure, which is depicted along the bottom, but we also have significant issues with cough, which Catherine will talk about. And often in practice, when you see a patient in clinic, if they have the beginnings of cough and difficulty with phlegm expectoration, then you need to be very much on the lookout for respiratory failure, because the cough problem generally comes first. And just briefly touching on the fact that we need to take it very seriously, because obviously we have evidence that we improve quality of life as well as survival whenever we initiate treatment for respiratory failure. So frontal lobe cognitive impairment occurs in maybe up to about 40% of patients with motor neuron disease. And why is it important? Well, if a patient loses capacity, then they obviously can't participate in advanced care planning. It's a very negative prognostic factor, and Orla Hardeman's group has looked at that, even in those without dementia, so you can have a cognitive impairment without dementia. It predicts functional decline. Patients are less able to cope with interventions such as non-invasive ventilation or gastrostomy. And often you will tend not to put them forward for intervention because you know that they won't be able to cope with that. But perhaps the most important thing to know about cognitive impairment is the increased carer burden. They almost always be the ones that refuse care, particularly home care, which is the bit that I think really does add to carer burden significantly. And I think it's up to care professionals to kind of try and push that, increase the understanding as much as possible within the family so that they feel a little bit strengthened to kind of push ahead and demand some help. But often the patient will refuse it. And often crises will hit. So as I mentioned, about 40% will have a frontotemporal cognitive impairment. And this can come in so many subtle ways, in apathy, in attention, in behavioural change, being obsessed with certain types of foods. And a number of years ago, they discovered that 40% of patients with familial motor neuron disease was explained by a gene called C9orf72, which is a hexanucleotide repeat expansion. It does account for between 7 and 20%, on average about 10% of sporadic motor neuron disease as well. These patients will all, obviously they have a family history. That's what, generally if someone has familial MND, they come with a family history. And until recently, that family history was just presumed to be that of motor neuron disease. But in these families, you will get a history of dementia, and that's when you need to ask, well, what age did they die? What type of dementia did they have? Was it a very young onset dementia? Had it a very strong behavioural element? You don't expect Alzheimer's dementia with these cases, but you do expect a frontotemporal type of cognitive impairment. And in turn with that, you will also have patients who have very strong family histories of schizophrenia, suicide, mental health problems. And those things come out of the woodwork only really when you actually start to ask about them. And there's sometimes a very high penetrance in families, and there are some families that are truly devastated because this gene has quite a high penetrance. It's not 100%, so often you tell patients who are perhaps the children of family that have motor neuron disease and frontotemporal dementia and are found positive for this gene, and you talk them through all the pros and cons. And yes, predictive testing is something that might be available if they can convince a geneticist to do that, but if they are positive for the gene, it doesn't mean to say that 100% that they will actually get the disorder. So it's a very difficult situation for families. I think it is the one area, while lots of people talk about stem cells, this is probably the one area where there will be developments, and developments first. So we have some really interesting, not me obviously, but genetic technologies, one in particular called CRISPR, which is going to potentially be revolutionary in terms of modifying genetic diseases. And so it is important for us to do testing to identify the families, because down the line, hopefully in only a few years' time, there may be technologies available to change things. Very briefly, obviously coming into this job in 2010, we looked back a little bit at the epidemiology of ALS, MND across the island of Ireland with Orla and Dublin. And survival was a little bit worse in Northern Ireland compared to the south. And we looked at some of the reasons why, and certainly the intervention rates were quite low in Northern Ireland, so lower rates of gastrostomy, lower rates of non-invasive ventilation in those years. That's changed a little bit since then. There was also no MDT clinic in Northern Ireland, and it's only really limited even now. And we looked and wondered whether those were some of the factors that related to why survival was poor in Northern Ireland. We looked at it in a little bit of a different way, and we accommodated for the fact that there was different interventions. And that actually wasn't found to be the reason why survival was better in the south of Ireland. It was felt that it was probably the multiple decision-making processes within an MDT setting that led to a kind of more enriched set of clinical encounters between patients and families. And I think that's really very relevant whenever you're trying to think about how you plan services. So I've got 5 minutes to briefly tell you about a study that Max Watson, Professor Watson, and myself, John McConville, the MNDA put together a couple of years ago, just to look at end-of-life care in motor neuron disease. It was a qualitative study done by Breach McLaughlin, one of the MND nurses there at the time. And it was a semi-structured narrative interview that she ran with what ended up being about 13 patients, because we really did reach saturation quite quickly. Symptoms were framed around symptoms, advanced care planning, psychological support, and issues around death and dying. It was about getting them to tell their story. And we used thematic analysis to analyse that. I'm not going to be able to go through that in great detail, but we had 13 patients, men, women, different tempos of disease, spinal and bulbar. About 4 had an advanced care directive, 5 were on NIV, 5 died at home, 1 died in hospice. That's a very brief, quick through. A couple of slides. Okay, so provision of holistic care. Some people have already seen these slides. I've modified them a little bit. But some of the important things that were drawn out from those transcripts. So hospice was a really positive experience. MND nurse was felt to be a great support. As though it's not mentioned, there were also times when people felt, so district nurse and GP support, whenever it was there may, that kind of feeling of support was also very important. Patients felt, however, in general, that staff had very little experience of MND. There was also significant issues, perhaps, in some people's transcripts about one example or one conversation was down here where I didn't contact her again as I didn't know what she did. She just kept saying that she didn't know why she was there. This is a regional piece, by the way. There's nobody being named or shamed. But it was simply just highlighting a little bit about perhaps when diagnosis hits and patients still look quite well, there may be some, people that haven't experienced MND before in terms of professionals, and therefore might not know about the future planning and the need to discuss at an early stage how people are fixed. Marie Curie nurses were always described with such great affection. Interestingly, there was a great problem with refusal. So refusal of carers, refusal of hospice, but on reflection, people would have said, as family members obviously talking, maybe if they had been involved sooner, he wouldn't have refused hospice. And that's a really key thing. Something that's really important that comes out in so many of the transcripts was that patients were very withdrawn. And that happens that happens very early. Sometimes it can be associated with a very poor delivery of diagnosis, and I think in one particular patient it was. So the transcript read, he was very quiet, he didn't want anyone, I think he gave up and he didn't want to be bothered. So that patient stopped going to his neurologist, wouldn't come to the respiratory clinic, and then, not surprisingly, ran into difficulties and was red light or blue lighted to a hospital in his last number of days and died very quickly. So interpreting that, I think we need to accept that specialist input can provide high quality care and not taking away from the strong community and sense of support that you get from GPs in primary care and district nursing. But in terms of negotiating your way through this condition, it's fairly important. There is a lack of engagement between patient, family and staff in some circumstances. Part of that is naturally due to a lack of knowledge. These are people regionally across Northern Ireland involved in different types of teams. There's also a fear within patients sometimes that accepting care signals disease progression, and perhaps there's not enough time to break down those concerns within patients because everyone's so terribly busy getting all the practical things in place, and time is of their essence and resources are very low. But emotional and psychological factors are massive, and they are such a massive block to a lot of what goes on in terms of lack of engagement between patients and professionals. So just very briefly, interestingly, some work in 2014 by Orla Hardiman's group had looked a little bit about what were the processes underpinning engagement, and they decided that they identified that control, reassurance and trust were key variables that shaped how people with MND engage. That meant, however, that people felt control, or people trusted professionals if they had control, and they could only have control if they were reassured. And so there's a lot of kind of psychological work that probably goes unrecognised as being an important component of the patient journey. Interestingly, the little snippet just below, denial is something you see as a coping strategy in many patients, and it can serve them well in the short term, but there is evidence to show that sustained denial and sustained wishful thinking is really unhelpful and relates to higher rates of anxiety and depression. And before I have to stop shortly, this is some new work from Italy about mindfulness and how it can be quite beneficial for anxiety and depression levels, negative emotions, and most importantly, the interaction. Oh shit, sorry. Oh yeah, there we go. Sorry. Interaction with people and the environment. So there you go. And I think that's something that probably hospices are actually doing, some work on mindfulness. Patients need access to formal psychological help if deemed appropriate, and they need it early, and that's not something we have in Northern Ireland. This may be required as early as diagnosis, and that's really key. These psychological problems are there when you first see these patients generally. And one other really important point I need to make is that towards the end, there's a number of slides we're not going to get through today, but towards the end of life, people have fear and anxiety as two of their most disabling symptoms. This is whenever, of course, they're away from the clinic, they're not coming in, they're not well enough to come to clinic, they're out in the community. Fear and anxiety are the big bigs, and what underpins a lot of that is actually a lot of respiratory symptoms, and therein lies the need for integration between palliative care and respiratory physiotherapist. Those are some of the big issues towards the end of life. And they do, and unfortunately the slides that won't have time to go into, but they are, and in this study, have shown to be some of the reasons why people end up being blue lighted to casualty departments in the last few days of their life, in addition, of course, to the lack of advanced care planning. But it's really important to recognise those symptoms. 1 minute left? So that was the second component of the study. As I said, we have unmanaged psychological symptomatology. Sometimes we have lack of anticipation. So That's in terms of respiratory care. Some patients do have, there's a lack of recognition sometimes in respiratory. These patients are a little different than the average patient coming into a respiratory department. They have very fast disease. You come to see a respiratory physician at a particular point in time and come back for review in 3 months. It's sometimes too long. These patients have deteriorated really very quickly. And that happens, and it's important therefore that patients are looked after not just in an MND clinic, but also attend respiratory services where the physician has sufficient experience of motor neuron disease. Patients need access to community respiratory teams that comprise nurse and physio with appropriate expertise and access to interventions, obviously such as NIV and cough assist, but most importantly, integration of both teams, and sharing and learning is the only way in which you can learn, of course, if you are integrated in the first place. And that's important for those that are planning services for neurology, for respiratory, for palliative care going into the future. So some of the recommendations from the advanced care planning is that we do need sufficient time for physicians to discuss advanced care planning, as well as an appropriate environment, and that's questionable in the confines of a very busy clinic. Other involved professionals, there were a number of threads and themes that came out of the qualitative research that patients had not picked up that their loved one was dying, but that some of the medical professionals had and hadn't shared that with them until after the patient had died. So I think lots of us do pick up on when someone is dying or in the last final stages, but families don't pick that up, and they often would really benefit from that discussion. And one of the other really important things is that discussing end-of-life care with the patient and the family together has been very unproductive for me, I think, in clinic. And if you ever have that opportunity to have conversations with family separate sometimes to the patient, I think that would be a lot more productive. But all professionals involved in the care of a patient needs to seize the opportunities to discuss advanced care planning, and then just share that with everyone else. And these discussions are not just simply to allow the patients to decide upon their care, but it really does facilitate family education and their involvement. And if family are prepped and ready and know what to do, maybe, just maybe, that might reduce the unnecessary hospital admissions, which really flavoured all of the 13 patients that we, not all of them, but quite a number of the transcripts. So a palliative care approach focused on symptom management and preservation of quality of life is recommended. Yes, we know that, but the key bit is that it's from the time of diagnosis. And that's a big key stumbling block in terms of policymakers that are trying to help create services. The fear that you're introducing someone to a diagnosis of motor neuron disease and then mentioning the word hospice, that barrier needs to be broke down. We already know that it works perfectly well in other parts of the world. People aren't scared once they get used to it. So the answer, yet again, we need streamlined care, we need integration of respiratory, palliative care and neurology. We need to address NICE guidance. We fall short of that within Northern Ireland. We do need multidisciplinary hospice-based clinic, at least for creating a kind of a specialist hub that can then be drawn from to be able to initiate things like outreach nurse-led clinics. And potentially down the line, where we have burgeoning clinics within neurology where we don't really do so much with the neurodegenerative conditions, maybe, just maybe, a template could then be born for neuropalliative disorders. That's all I have to say, so apologies for over time.